engage with us around the challenges of fostering cognitive integration of basic and clinical sciences in the minds of our learners. And we will introduce you to a novel integration tool developed by Aquifer, the Integrated Illness Script.
And Amy? Hi, I'm Amy Wilson-Delfosse, the Senior Director of Aquifer Sciences and Associate Dean for Curriculum and Professor of Pharmacology at Case Western Reserve University School of Medicine. We are enormously pleased to welcome you to our web shop today and to introduce you to the coaches that will be working with you in your breakout rooms. Robin English is Professor of Clinical Pediatrics and Assistant Dean for Undergraduate Medical Education at Louisiana State University. Tracy Fulton is a Professor of Biochemistry and Biophysics at the University of California at San Francisco. Dave Harris is Associate Professor of Physiology at the University of Central Florida. Kit No is Assistant Professor of Basic and Clinical Sciences and one of my favorite administrative titles, Assistant Dean for Innovation. James Nixon is actually not able to be with us today, but a really highly valued member of our leadership team. And Leah Sheridan is Associate Professor of Physiology at Ohio University. So now that you know who we are, we would love for you all to share with us and your co-attendees who you are. Unfortunately, even with 2 hours today, we don't have enough time for everybody to verbally introduce themselves, but please take a moment and place your name, your title, and your institution in the chat feature of Zoom. We will all appreciate getting to know you that way. All right, thank you. The names are starting to come in. Oh, Senthil, great you're here. Glad you made it. We have a bunch of people I know that were registered from Geisinger Commonwealth. Yeah. Starting to see them come in.
You guys will get a chance in your breakout rooms to really introduce yourselves to each other a little bit more as well and get to know some of your colleagues today at the web shop a little bit more as well. So thank you for putting your information in the chat. So a couple of web shop norms that we like to make sure that everybody's sort of on the same page. So as a general rule, please keep your camera on and yourself muted when you're not talking. This gives us an opportunity to get to know each other a little bit and get to know faces a little bit as well. So obviously, we're all grown-ups. If you need to turn your camera off for a little bit, that's fine. But in general, we'd love to have you keep it on. This is meant to be interactive. It is really a web-based workshop. So, prepared to be, answering questions, asking questions, and diving in and being called on at times as well. As you've already seen, our coaches are all here as well. And so if you have a question that's related to what we're presenting today, if you're confused about something, but we're in the middle of a presentation, please feel free to post it in the chat. Our team is watching the chat as well. So happy to do some back channel with you as well. We encourage you also to just put insights into the chat. If all of a sudden you have an aha moment or it's relating to what you're doing in your school, feel free to pop that in the chat as well. It gives Amy and me a chance to better understand what maybe to pull out in a discussion and or your colleagues on the web shop today to really connect with you around what you're doing. That's part of the intent today as well, is to get to know some new people who are interested as you are in some very, very similar things. And then also when we come to the point in the web shop where we ask you to access the chat and some of the PDFs that are the worksheets we'll be working on today, please don't forget to actually download them on your computer, because once you download it and open it up, they're all writable PDFs, so you'll be able to do your work, your homework in that PDF as well. So just don't forget to open it up and actually download it to make it function well for you too. And if you have any challenges in the workshop too, my whole entire staff is on the back end as well. So please don't be shy about asking for some help for something specific logisticals as well. Our learning objectives are shown here and really include the steps required to develop an integrated illness script. So our intent really is by the time you're done, you should have a pretty good sense on how to do this. And we'd love to hear from you how you've done it at the end and in the next couple of weeks to months, how that's working for you as well. But we really hope you walk away with some really great tools and skills to do that. We've also provided you with a reading list of some references, a few of which we hope you have had a chance to review prior to coming today, and some that you may really wish to review following the session. But this is really both a combination of things that really extend the work that we're doing. A few of these I'll talk about a little bit later on, but also the intent is really to give you some nice background reading to advance your understanding or thinking about either what led to these or how you might integrate them going forward as well.
We'll start the web shop with a brief didactic, and then we'll practice the steps needed to create. Actually, you'll be creating an integrated illness script as a large group and in breakout rooms. We're going to send you to the breakout rooms after we do some large group work where your coaches will be there to help you complete an integrated illness script. When we come back together as a large group, we'll review your work. And then we'll have another short didactic and a second breakout group. And finally, we'll end the workshop together with a concluding discussion. So, okay, but before we dive into our first mini didactic, we'd like to ask you to take 60 seconds to just think about the prompts that are shown on this slide, considering the challenges of integrating the teaching and learning of basic science and clinical medicine. And please select the one that seems most relevant to you. Okay, just take a minute now and think about this. I'm going to time you. Okay, now go ahead and start entering your thoughts into the chat window. If everybody could just, yeah. Oh, getting people to emerge from their academic silos and collaborate. And time to have those discussions across disciplines and to think creatively. Our leadership team, Leslie and I, we've been doing this for 8 years now. And, we still have those times where we don't communicate as well as we would like to, because basic scientists and clinicians really fundamentally think differently. How far down the rabbit hole can I take my students? Wonderful question. Yeah, Leah, right? And making sure that what we're teaching as basic scientists is really clinically relevant. Compartmentalizing their learning. That one went by too quick. I wanted to see that one. Make little effort to read concepts taught once the exam is over. Such a great point, Michael. Yeah. Okay, A10, actually, I had no challenges. Basic science faculty was more eager. That's terrific. Wonderful. You're in a great environment. So many challenges, right? For a clinician, the basic science is too far removed from what they're actually doing. And so much of the work that we're going to be talking to you about today really helps the clinicians to think about basic science in a way that's meaningful to them as they're practicing clinical medicine. And Central faculty not having time, right, so much of it is about time. Thank you so much. Please, as Leslie said earlier, as you have thoughts, share them in the chat window. Even if we don't have an opportunity to read them right now while we're presenting, we will go back later and we will read. And we really so much want to learn from you. So please do use that chat window robustly. Leslie, I'm going to let you take it away.
Sure, sounds great. And I love Paul's last comment there. It's very, very near and dear to our hearts as well. So let's talk a little bit then about what we like to call cognitive integration in action, and sort of set the stage and set the framework for how we move ahead from some of the challenges that you all are talking about and we have faced as well. And so a lot of why we did what we're doing here as well. So prior to starting our work, two very strong models of curricular integration had already been disseminated and were in widespread use. So published in 2000, Ron Harden's model described this ladder of integration to be climbed by curriculum deans and their faculty as they moved out of isolated curriculum planning and teaching up through the various stages of first harmonizing and then progressively integrating efforts between departments and courses. And many of you and some of the challenges you're talking about here, I think a lot of this ladder was designed to help with those challenges, and in fact has actually. I think some of the work we're seeing already, people beginning to realize how they need to come together, really came out of some of Ron's early work there as well. And then in 2012, Ellen Goldman and Scott Schroth took a more granular and tactical approach, really starting first with the programmatic integration and then working backwards through course level and then session level integration decisions. And so I think, again, many of you guys are really talking about this, is how you have to think about your curricular program first, make some curricular decisions and some integration decisions, then you move to the course level, then you move to the session level. And we really found these frameworks really useful initially in thinking about what we wanted to create, but we really felt that they lacked this focus on learning level integration that our team and our project really sought to do. Luckily for us, right around this time, Mahan Kulasegaram, Nikki Woods, and many of their colleagues at the Wilson Center in Toronto, and these are many of our references come from their work, published their groundbreaking framework. And in this 2013 paper, they asserted that meaningful integration is a cognitive activity and that it occurs first and foremost within the minds of the learners. They concluded by promoting the use of learner-centered, content-focused, session-level curricular strategies to achieve this objective. So it was in this context that we really chose to focus our pedagogical approach on developing integrated illness scripts and mechanism of disease maps for the most common core conditions encountered by learners in their clinical training and the core biomedical concepts that underpin students' understanding of these conditions. And so really, we really proposing that it start with the learner and go back up to the session and go back up to the course and go back up to the programmatic level, or at least there be some bidirectional activity, because frankly, at the end of the day, if it isn't integrated in the learner's head when they leave the program or course or session, our objectives haven't been met. So we chose this idea for our own learning tools and resources, this idea of integrated illness scripts and mechanism of disease maps. So that's where I'll talk a little bit more about how we got there. So an illness script is the term for the mental model by which a clinician stores and recalls relevant biomedical concepts and the relationships to clinical problems such as diseases, conditions, or syndromes. Expert clinicians draw from this repertoire of their scripts, developed and honed over years of experience, to drive very purposeful clinical data gathering, comparing and contrasting diagnostic hypotheses, which we'll talk about again at the end, and then direct initial management decisions, as some of you have talked about how you're doing this work in your own schools as well. Novice clinicians naturally begin this process of illness script development in the moment they begin learning about diseases and conditions. So targeting these earliest learning experiences and then building integratively on top of them is the primary aim of our Aquifer Sciences initiative and our pedagogical approach. In the traditional model of an illness script, knowledge of each clinical condition is organized within a clinician's memory into three main components. The enabling condition, or really the predisposing epidemiologic and structural factors that influence a patient's probability of the disease. The fault, or the initial trigger or underlying pathophysiologic insult brought about by the enabling conditions. And then the clinical consequences, or the patient's chief concern, signs, and symptoms to which that fault gives rise. Importantly, though, the research demonstrates that how a clinician encapsulates this relevant information within these components in their own mind facilitates or hinders accurate and efficient information retrieval during clinical decision-making with patients. So as an example, here's an illness script for asthma, organized in the traditional format. On the surface, this appears both succinct and nicely integrated, providing novice learners with a cogent cognitive framework for learning and applying both the basic sciences relevant to asthma gained in the pre-clerkship curriculum on the right, and then adding and integrating the more clinically relevant information gained during their clerkship education on the left. Initially, this is exactly what our team planned to create. Many of you may have thought about doing something very similar in your own schools or your own organizations. And the clinicians were really pleased with this approach. We thought this is a great idea. However, the basic scientists on our team really felt strongly that we were still missing something because the basic science still felt too segregated and set off to the side. Luckily for us, once again, our colleagues at the Wilson Center had recently published a paper in the dental educational literature that answered the concern and suggested a much better approach for us. In this study, published around the same time as the cognitive integration paper, they asked dental students to learn about 4 dental conditions diagnosed by X-ray that are easily confused. Half the students learned the conditions using the standard framework called segregated in this study, and the other half were taught using a more integrated approach. In the segregated approach group, a concise paragraph teaching the basic science mechanisms for each condition was provided, followed immediately by a paragraph outlining the diagnostic, clinical, radiographic features of the condition, much like the traditional illness script structure I just showed you for asthma. When given unknown radiographs, students in the segregated approach group correctly diagnosed the condition 70% of the time immediately following the training, and dropped to 86 to 68% accuracy a week later. In the integrated approach group, each condition was taught with the same basic science content, underlined here in blue, integrated with the same clinical radiographic feature content, underlined here in orange, in a deeply integrated sentence by sentence fashion. So as you can see in the results, the worst performer in the integrated approach group in the delayed testing still outperformed even the best performer in the segregated approach group during the immediate testing. And to me, this is actually, I think, one of the most important papers that we've read on this topic, and I would encourage you to take a look at it more. So thus, our idea for developing integrated illness scripts really was born from this paper and from this approach and this idea. So continuing with the asthma example, an integrated illness script begins with the definition of an illness, followed by a description of the underlying pathophysiologic insult or the trigger, and the epidemiology of the enabling conditions. This overview is then followed by a list of the most common clinical features of the condition, each with its own detailed description of the basic science causal explanation for why this feature occurs in this condition. So for example, the basic science explanation for why dyspnea occurs specifically in asthma. As an added component, our integrated illness script approach also includes the basic science core concepts derived for us from our curriculum that we've published that underlie each described causal mechanism. In this manner, the integrated illness script provides a support for the inductive clinical reasoning from the observed feature back through the relevant causal mechanisms and basic science concepts to the original insult. We'll talk a lot more about that today as we create them together. The accompanying mechanism of disease, or MOD map, as we refer to it, the development of which we actually cover in a different web shop. So if you'd like to come to that, we'll tell you a little bit more about that at the end, is a unique type of linear concept map that provides an integrated basic science visual representation of the illness. Starting with the original insult, the MOD flows in a deductive causal manner, consistent with the way a basic scientist would explain the occurrence of a given clinical feature in a known disease. So really flowing from the insult out kind of an upside down tree fashion to the clinical feature at the end. Taken together, the integrated illness script and the mechanism of disease map provide a holistic, cognitively integrated and clinically relevant overview of asthma that may then be used broadly in clinical decision-making by students and or clinicians. And I'll close this section by just suggesting to you, based on what we saw in the paper as well, that our current methods of programmatic integration, while an improvement from what we used to do, are still segregated. So as you can see in many schools, we have good problem-based learning sessions in which we really do a lot of good clinical correlation with the basic science that we're teaching. Or from the clinical side, we do some nice basic science correlation by asking an internal medicine, medical student to go look up the basic science explaining something. But if you really think about it, by doing it at that level, it's still relatively segregated. So let's turn our attention to getting you started on writing an integrated illness script for asthma for yourself. So hopefully you were paying attention. Our team is providing you in the chat with a writable PDF for your work. So if you haven't already, please do take a moment to download and open this up on your computer. Remember, click on it in the chat, open it up, and download it. While you're doing that, I'll also point out that for some people just need to see what this looks like before they can work on it. My husband's one of those people. So for those of you who really wish to see sort of what a completed integrated illness script looks like, we've also provided in the chat a PDF of a completed worked example for pneumothorax. So you've got a complete example of what pneumothorax looks like as an integrated illness script, as well as a handout that you're going to start working on with us to create one for asthma as well. And thank you, team, for doing that. Please let my team know if you have any challenges downloading those or accessing them. So to get us off the ground to begin with, it's important to understand, as I said previously, that an integrated illness script is structured around inductive reasoning. So in other words, beginning with the clinical feature that is discovered by a clinician, and then using the basic science causal mechanisms to reason backwards to the proposed underlying insult, much the way a clinical clinician needs to reason. So here's an example of how that looks for the observed clinical feature of dyspnea. So you can see dyspnea, patient's dyspneic, leads back to the clinician thinking, okay, dyspnea is caused by this mechanism, and then thinking back to and what triggers that? What causes that in the first place? So that then a basic scientist could go the other way with deductive reasoning, saying, here's what triggers badness in asthma, here's how it works, and here's what you see. So today in the integrated illness script, that's the MOD map, in the integrated illness script, we're going to work like clinicians and be inductive about everything. We think one of the most important things that we've done, however, with this idea of integrated illness scripts, though, is bring in, which the original research didn't also include, although their other research heavily supports, is to also clearly articulate the foundational core basic science concepts or concepts that underlie the mechanism. This is critically important as it is conceptual understanding that promotes transfer. So if you've got a learner who's now going to go take care of another patient with dyspnea who may or may not have asthma, they need that conceptual foundation to then take what they've learned from one problem and apply it to a different problem. That's known as transfer. And we'll talk about this a bit more at the end as we start to wrap up the webshop today as well. So an integrated illness script presumes that the learners have already had a foundational basic science understanding of how the human body normally functions and leverages this understanding to explain the scientific basis of disease. So if you're getting started writing integrated illness scripts, sort of figure out where your learner level is. For us, it's recognizing the students have already learned the basics and now they're moving on to the scientific basis of disease off their understanding of how the human body works. In our project, we have intentionally chosen to develop illness scripts for the most common core conditions students encounter in their clinical rotations. In developing your own integrated illness scripts, you may choose your conditions for different reasons, such as a condition that is infrequently encountered, yet provides learners with a classic example of an important core concept in your course or that you really want them to grasp, particularly in the earlier components of your curriculum. Whatever your reason, though, we highly recommend that you make the rationale for your choice clear to your learner in order to provide them some important context about when, how, and why they may expect to apply the learning from the script work in their clinical settings and not just make this busy work. Finally, before you begin script development in earnest, please be sure you and/or your learners have a deep understanding of the key basic science and clinical literature relevant to the presentation of the core condition, including the prevalence of the clinical features at the time of presentation and the foundational mechanisms behind the condition and the epidemiology. We won't have much time to talk about that today, but you will see both the integrated illness scripts we're providing you have a long list of references at the end. And I will tell you, not starting here is at your peril because you'll have to rewrite and rewrite if you don't start off with a really good evidence base for this. And we won't, as I said, have a lot of time to deal with that today as well. So let's talk for a few minutes about the epidemiology section, which we won't have you do today in the interest of time. For this reason, we've already populated your handout with the epidemiology of asthma. But to be effective yet concise, the epidemiology section should contain key information about the prevalence, relevant geography, and any pre-existing or enabling conditions or triggers that predispose a person to this disease. Importantly, to the extent that it is known, the basic science mechanisms that underpin each of these factors should be included. And I will say, even in our group, this is still really hard to get people to stop and ask, why is this epidemiology from a basic science perspective unlikely to be happening? If the mechanism isn't known or controversy exists, this should clearly be stated as well. That will really help our learners know when we're like, we don't know, but we know it happens, versus we just haven't explained to you why it happens, and taking the time to do that. We also ask that you pay particular attention to ensuring that references to predisposing factors due to heritage or sex should really only be included if they are supported by the evidence, and that the mechanisms of disease and are clinically relevant. We have really spent a great deal of time and effort to bust many outdated myths in this area, and we really encourage you to continue this work as well. So we've discovered that one of the most important aspects of an integrated illness script is what we call the underlying pathophysiologic insult. And since that's really hard to say many times fast, we lovingly refer to it as the UPI, UPI, the UPI, or the underlying insult. This is a concise description of the basic science genesis of the disease. So really, like, all things were going beautifully in this normal human body until this thing happened. What is that thing? And it really, I think in many ways, you'll find that this is really follows through most of the teaching you want to make about the organs, cells, tissues, molecules, and the genes of the condition really find their way here. And the relevant core concepts from these disciplines are also contained here. We did not do that in our example for the sake of some space, but also in our illness scripts in the UPI section, we also include pathology, genetics, and other relevant core concepts there as well. All right, lest you be sick of me talking, now it's time for you to practice. So for the next 8 minutes, what I'd like you to do is work silently on your own to author a clinical definition of asthma, and then to articulate what you see as the underlying pathophysiologic insult for yourself. After this, we'll share our own description, and you can see how close you came, but for about the next 8 minutes. So that'll be, let's see, about 4:07 on my clock. We'll give you some time to work on both of these in your PDF, and then we'll come back and see how you did. Okay, so 8 minutes to my team for them to practice. Go. All right. I know you all are working really hard, so you'll actually have a chance to come back and take a look at this. If there was some piece of this that you're not excited about yet, we'll come back to that as well, but let's go ahead and move on. So here's our definition and our UPI, and know that obviously we had a little bit more time than 10 minutes to write these, but I'll just let you take a minute here to read them and then to consider them in the context of what you wrote. Okay, so moving on. The next component, and really the heart of an integrated illness script, are the clinical feature boxes. So one box is created for the top 4 to 6 clinical features that are the most commonly present in the majority of patients at the time of disease presentation, which are defined at the outset during your literature search. So this is really important to do your literature search and really identify from a prevalence perspective what most patients with this condition present with as their top 4 to 6 features at the time of diagnosis. Like the script itself, each feature begins with a textbook clinical definition of the feature and how a clinician would discover it during the history, physical exam, or routine initial blood work or imaging. So we do use some blood work and some imaging, but only if this is something that is practically inevitably gotten at the time a patient presents with something, so like a chest x-ray or a CBC, for example. The other is we're really taking the time to create key clinical definitions and how it shows up to a learner, helping them to better recognize their physical exam skills out of this as well. This is followed by the causal explanations for how this feature presents in this condition. And so like the explanation, directly linking, so this is linking the explanation directly back to the definition of the clinical feature. it really, and this is what I sort of call the corkscrew, and not even ours are yet all the way I think they should be. But what you really need to do is begin with what's gone wrong. Don't begin by explaining what the normal physiology mechanism is that led to this. Really begin with how that feature initially happened, and it comes from what, and it comes from what, so that a learner can really start with the finding and the feature that they see in front of them and literally peel back the layers of how that came to be. And it's very counterintuitive initially to write it this way, but that's the way really to think about it. This explanation really should also show the transfer of the core concepts I'm going to tell you about in a minute to this feature in this condition. And the depth, and you guys, some people already brought this up about rabbit holes and things like that. The depth is really dictated by the mechanistic information needed to differentiate between clinical conditions with the same clinical feature that presents similarly. So if you're asking yourself, how far down should I go in the details? Ask yourself, is it clinically relevant to helping a learner make the diagnosis or come up with the right diagnosis in a differential diagnosis? And understanding the need to understand this to make a safe and effective decision for the patient about further workup and management. So we really have found these rules to be very helpful when our basic scientists in particular really want to go down into the details. And then lastly is the 2 to 3 basic science core concepts that underpin the mechanistic explanation are then provided. And you guys will see the core concepts for asthma in your handout. It's really important to note that this is not merely a list of concepts. You should be able to select which sentence or sentences in your mechanistic explanation are supported by the concept you've chosen. Furthermore, you should ensure that the concepts themselves, the 2 to 3 that you've chosen, integrated together, provide a learner with a deep integrated conceptual understanding of dyspnea in asthma. Just not the mechanistic explanation by itself, but what are the integrated concepts underneath it from how the body works that explain it. And we'll talk a little bit more about this at the end, but I want you to really keep that in mind. Okay, here you go. The fun really starts now. So it's your turn to give this a try using the clinical feature of cough in asthma. And you've got the PDF in your handout, so just scroll down to the next section. So we're going to give you about 10 minutes to quietly, once again, work on your own. So start your own by yourself. And what we want you to do is to write a clinical definition of cough. So how would a learner find out that a patient with asthma is coughing? So what's a cough and how does somebody find out that someone's coughing? And the basic science causal explanation as to why patients with asthma cough. And then finally, using the list of core concepts at the bottom of the PDF, choose up to 3 core concepts that foundationally underpin the explanation you've just written above. And as I've said, as you do this, think too about how they integrate together to explain cough in asthma. So we'll give you 10 minutes to go ahead and work on that. So we'll work on that till 4:24. Work quietly on your own, and then we'll go ahead and talk through it again. Okay. I promise you're going to have a chance to work on some more of these and actually getting to interact with each other and writing some more of these too in just a minute. So let's go ahead and move on.
Okay, so admittedly, we had a lot more time than you did to complete this work. So your responses might not be quite as thorough as what you see here, but go ahead and take a look. And note that we start out providing a definition of cough, the causal explanation that describes why a patient with asthma has cough, and moving through the mechanistic detail of cough. Okay, and then finally, we selected the relevant underlying concepts that support these mechanisms. So you can see here, structure and function of the CNS, PNS, and chronic inflammation are the concepts that we selected from the Aquifer Sciences curriculum that underlie those mechanisms in this causal explanation. Okay, so are there any questions about the process of just completing the worksheet, the template for a clinical feature. Because you might guess we're about to send you back out to breakout rooms. So if you have any questions, please just unmute. Leslie and I try to address anything. Question in chat: how long does it usually take in a real student setting? That is a fabulous question. We actually ask our clerkship year medical students at CASE to complete an integrated illness script and a mechanism of disease map in about 45 minutes. They're not always super pretty, but honestly, they are way better than you would ever imagine somebody could accomplish doing that in 45 minutes. Our team spends days, weeks, months actually trying to get these things really refined and beautiful. But in the classroom, if you've got an hour, certainly you can get through this, I think. Okay, so we're going to move along. We're now going to send you out into breakout rooms, and you should see a document in the chat window. I'm going to ask our team to go ahead and repost that if they haven't. You should already have it, okay, but just in case something happened and you don't, we'll go ahead and put that back in for you. And we're gonna, if you haven't already, again, please, go ahead and download this. Each breakout group is going to have an Aquifer Sciences facilitator, and they're going to tell you which clinical feature your small group is going to work on. For your assigned clinical feature, please work together as a team to go ahead and complete the definition of that clinical feature, the causal explanation for the feature, and go ahead and pick the underlying core concepts. And if you scroll almost to the end of your PDF, you'll see all of the relevant Aquifer Sciences concepts there. You just need to pick which ones are relevant. Please be sure to designate a spokesperson to share your work when you return, because we might be calling on you. All right. Enjoy your breakout rooms. Okay. I think we might have everybody back. Welcome. All right. We're gonna ask you to do some report outs, and I know report outs can feel a little painful, so we're not gonna ask every group. You can see which of your coaches is most aggressive in trying to get their teams in to share their work. So let's go ahead and start with wheezing. So Robin and Kit, do you guys want to virtually arm wrestle to figure out which of your teams can share their screens?
My team did great. We didn't get as many words on the page, but we had a really good discussion. And I don't know, Kathy, do you want to share? We got the concepts, and so go ahead, Kathy.
That's terrific. Yeah, go ahead and talk us through it, Kathy.
You're on mute.
We kept the definition very simple, saying it was, for wheezing, it was a continuous musical sound heard during expiration, but can also sometimes be heard during inspiration. And then we were talking a lot of other things, but that's why we got to going to wheezing is caused by, we had the inflammatory mediators, we named a few. I wasn't typing as fast as I should have been. And then bronchoconstriction, causing obstruction, causing the airflow, which causes that noise. So we circle back to what causes the wheeze. Oops, and the concepts didn't show. I'm sorry. Maybe I typed them somewhere else. I typed them in the wrong place. Okay, so the concepts we had were chronic inflammation, immune mediators that cause the chronic inflammation. And then we also should have bronchoconstriction, and then an abnormal flow gradients that cause the wheezing. So sorry, we were just kind of throwing things in at the end. Yeah.
No, terrific. Thank you so much for sharing. And I think what you probably learned in your breakout group was you need to talk through this stuff a lot. And having clinicians and basic scientists together, you just have to kind of keep pounding away at it sometimes before you're really ready to write all those words down. So thank you. Okay, so let's move on to dyspnea. So Tracy and Dave, they're both very competitive. So I'm anxious to see which of their teams is going to get to share. Who volunteers first?
Well, I saw in the chat that Dave claimed that their group got all 4 concepts.
All
So
right, we're going to hear from them.
I'm just
All
going
right.
to throw down and
All
say we did great too.
All right.
Do you want to share, Mark, and lead us through that, or any of us can?
Told you they were competitive.
So we had dyspnea, difficulty breathing. And so we came up with a number of ways that patients explain that: catching my breath, short of breath, feeling chest tightness, and things like that. And then, of course, the physical exam findings are heavily breathing and dyspnea. We tried to order this. We had talked a little bit. This is probably where we spent the most time talking about how the order of how these things occur. Inflammation being the underlying problem, which leads to edema and more mucus production and air trapping and hyperinflation, and then the mechanoreceptor activation and then chemoreceptor activation. And then as far as concepts go, we did the 2 that I think fit the best was chronic inflammation and regulation of oxygen and carbon dioxide, but all 4 really fit here in one way or the other, as getting air through the airways and things like that. So flow is in there as well.
Okay.
Anybody else in the group want to add anything?
Dave, any comments?
I was just spiking the football for Tracy, but
Okay.
no, they were right on. So I mean, that's what, what I was really trying to push them for was to hit sort of the main points, because I said it takes time to really put that causal mechanism sort of together with the cognitive integration. But I think we have the pieces there.
Okay. Terrific. All right. And Leah, you don't have to fight with anybody because your team was the only one that did hypoxemia. So
Oh, we would have won anyways.
I suspect you would have. So anybody from Leah's team ready to share? Thank you. You guys are superstars at doing the Zoom share, by the way. We're all very well practiced.
So since we're the only ones, then we can't go wrong.
Yeah, nobody's wrong.
Yeah, so we had hypoxemia and talked about it as a condition of lower arterial PO2, and said that we can measure it by ABGs and pulse ox. And we were discussing whether we include other clinical signs of hypoxemia, like air hunger and tachypnea and things like that, but decided that that would be better for like the dyspnea section. We talked about VQ mismatch, obstruction of the airways because of inflammation, bronchial constriction, and then had 3 basic science concepts with chronic inflammation, regulation of oxygen and carbon dioxide, and then flow gradient abnormalities.
Terrific. And I saw Dave Harris doing the head bob a lot while you were talking, Holly. So not only your coach thinks you were awesome.
Thanks.
Our other physiology is giving you props there. All right, really nice. We are going to share with you our worked example, and we'll throw that in the chat in a minute. I do want us to take a few minutes though now talking about how did this feel? Okay, going into those breakout rooms, working through this. In many cases, we have basic scientists and clinician educators that were in your breakout rooms. How did it feel? And please, you're welcome to put things in chat, but we're a small enough group. Go ahead and just unmute your microphone and tell us how it felt.
It was easier than individually.
Right, so the value and the power of the team.
Yes.
I love how much smarter the team is than any individual. It felt productive. Yeah, it's kind of a good feeling, isn't it? active listening was important, as was hearing another's perspective. Such a great comment. Again, basic scientists and clinicians working together on this kind of work is not something that just happens naturally all the time. And it really does require effort, like active listening. It was refreshing, great to integrate for deeper answers. Does anybody else want to unmute and just tell us in one word, how did it feel? Michael, how did it feel? Just one word.
Awkward.
Awkward. No, terrific. Tell us a little bit more about that.
Well, I think it's just more a matter of, this is the first time we've sort of seen the framework.
Mhm.
I think it's just a matter of not being familiar with the exact assignment, and kind of coming up with some of our discussion was, well, someone who has hypoxia is going to be air hungry, but air hungry is dyspnea, and that's not our problem. And so it was just a little difficult to figure out exactly where we needed to go, because it's a big problem when we're just looking at one little piece of it. So I think it's more a matter of not having had prior experience with this model or working through the entire problem as opposed to a small piece of it.
Mhm.
So it's not insurmountable. It just felt a little bit, are we doing what we're supposed to do or not quite?
Yeah, and Leslie may want to say something about this, or other members of the team, but we learn as we go. We are learning from this workshop, I can tell you right now. And I think this is how what we create just gets better and better.
Amy, the one thing I was going to make a comment on that is that's how our we have sort of that background knowledge that we can put like hypoxemia and dyspnea together. I'm not convinced our students have that. So that's what we're trying to build.
Okay.
To me, it felt like being in the clinic and talking to a mom and explaining why her kid behaves the way they behave when they have an attack, and what it looks like early on, and why it's important to go ahead out and get that peak flow meter that I prescribed, because it's going to give you information in advance so that the attack doesn't feel like an act of God that fell out of the sky like stones on Chicken Little's head.
Yeah, James, thanks for sharing that. One of the things that I love to do is to take an integrated illness script or a mechanism of disease map, which if you come to our next web shop on June 22nd, you'll learn all how to create the maps, but to take those and translate them for a patient so that you can actually describe step by step what's going on and why does your child have wheezing. We're going to go ahead and move on. Please, if you'd like to continue sharing your thoughts in the chat window, we'd love to see them continue to come in, and please do continue to post any questions you have there. Leslie, you want to take it over?
All right. So we want to wrap this up as we're heading down to the end of the hour and talk a little bit about this idea of conceptual integration and transfer. Sort of like, why are we doing this? Why are we putting together illness scripts, and why are we talking about these clinical features the way we're talking about them, and the concepts the way that we're talking about them as well. And so I'm bringing you back to the slide that I showed you earlier, which is this idea that when you stop to think about the causal explanation box the way you have, how you work through the interrelatedness of the definition with the causal explanation with the core concepts, and how those all have to sort of integrate amongst each other. But I think it's Kathy who brought this up again in the chat, and here's a little bit of a vignette I want you guys to begin thinking about, because this is not just a classroom activity. The point is really to get our learners to be cognitively integrated to take good care of patients. So here's an example. You have your clinician meeting with Jessica in the office and saying, I'd like you to see Mr. Payne, our patient. So don't worry too much about this. This just kind of puts you in the right mood here. But Mr. Payne's a 56-year-old man who's arrived today for an urgent care appointment with his primary care physician, and he's concerned about his shortness of breath and cough, which have both been progressively increased over the past 3 days. He's had a history of poorly controlled asthma as a child, with occasional flares as an adult when the seasons change. His symptoms usually resolve with an inhaled beta-2 agonist. He leads a relatively sedentary life. He works 12-hour shifts as an operator in a busy call center, and his lab studies during his last health maintenance visit were suggestive of prediabetes. So, fairly typical patient that a learner may see. So here's Jessica in the room with Mr. Payne. And as we know from what we talked about previously, he's giving her his history and telling her what's going on. She'll do a physical exam, and she's sort of trying to integrate in her head what she learned in the basic sciences about respiratory physiology and how the lungs work, and also what she's learning clinically about how patients present and what might be the differential diagnosis that she needs to think about with respect to Mr. Payne. So she leaves the room and her preceptor asks her, so what's your differential diagnosis for Mr. Payne's dyspnea? So as those of us who are clinicians, and many of you basic scientists know, is the way that we clinicians think through differential diagnoses is to say, okay, so one of his chief concerns or prominent features is dyspnea. And then we start to think through a differential diagnosis. From a learner's perspective, particularly early clinical learners, we typically ask them to think about at least 2 core conditions that are most likely and is also common, and it could also be considered likely. And then probably a third one, although sometimes it's the second one, that is still likely based on the patient's presentation and all the etiologic factors, but is of concern. And if in fact is real, may need to be addressed relatively early. So here we have, one could consider dyspnea for Mr. Payne being asthma, because he kind of has a history of it, pneumonia, common condition, but you know what, he's sedentary, he works in a call center, maybe he has a PE, maybe he has an undiagnosed DVT, and that's what's causing his problems now, and you don't want to just assume it's his asthma, for example. So then what our learners do, and this is again what we teach them to do, is take a really good history and do a really good physical exam and start to organize and order their features as they're seeing them. So if this patient has asthma, he's got epidemiology of a past history consistent with it, a chronic cough and wheezing on his lung exam. Same could be said true of pneumonia. He's got an etiology consistent with it. He's got an acute cough, and he has crackles on lung exam. And then she has to think through pulmonary embolism and think about what might be some of those things. So yet again, a chronic cough. He's got an epidemiology to support it. And she'd have to look for evidence of a deep vein thrombosis. So you can see in her physical exam already, she'd want to do a lung exam, look for wheezing, look for crackles, and look for evidence of a DVT to begin thinking about these things. This is classic clinical education about a differential diagnosis using your history taking and physical exam skills, and that more traditional disintegrated illness script. Now, given what you guys just did though, you can begin to think about how she might also do her differential diagnosis using compare and contrast of the causal mechanisms. So you can see here, while he has dyspnea and a lot of reasons to potentially have each of these conditions, the mechanism of his dyspnea in each of these conditions is different. So if he has asthma, there's one mechanism for his dyspnea. If he has pneumonia, there's a different mechanism. And if he has a PE, there's a third one. So imagine now her being able to extend her thoughts about her differential diagnosis based on her conceptual understanding as well. So when her preceptor says, how do you recommend we manage his dyspnea at this time and why? So now she's got to not only go through her differential, but she's got to think about actually doing something to him, and depending on what he has and the mechanisms being different, what she chooses to do may be right or wrong, depending on whether or not the mechanism is the correct one that she's chosen. So luckily she was taught by Dave Harris, who I have to tell on occasion, not every single thing in the human body is due to flow gradients, but we've discovered many of them are. And so she stops and thinks, I think it's all about managing flow gradients. So imagine if she thought this way. This is the idea of conceptual transfer. is taking this idea of flow gradients and thinking about how they apply across the body. So she's going to take that and use it to solve a new problem. So for example, if you can think about flow gradients, you can think about blood flow through the tubes in the heart. You can also think through air flow through tubes in the lungs. You could also think about flow of tubes in the glomeruli, for example. So flowing through tubes in the human body, as we know, is a very common concept to understand, but applies in very different ways across the body. So how might that be true then if she'd actually done an integrated illness script for all three of these conditions and is now trying to think about dyspnea in each one of them? So if you start to think about flow gradients in these conditions, there's a different disruption to flow that's present in dyspnea for each of these conditions. So if in fact all of them have pulmonary VQ mismatches, but a different causal reason for that. So in a PE, it's blockage that leads to decreased pulmonary flow. In asthma, it's decreased pressure gradients due to bronchoconstriction that leads to decreased ventilation. And in pneumonia, it's decreased compliance of the alveoli due to pus and fluid that leads to decreased ventilation. So you can begin to see how she might begin to use this conceptual understanding in her differential diagnosis. And most importantly, understanding those mechanisms means she understands that the management decisions need to be different because the mechanisms are different. So if he has a PE, we have to open up flow, thinking about thrombotics. If he has asthma, we have to relieve the bronchoconstriction with a bronchodilator. If he has pneumonia, we have to improve his compliance. He might need positive pressure O2, for example. So it's really interesting as you start to march this out, you begin to really recognize, wow, those treatments are really different. And they really are different based on the differential, but they all come from different management of the same core concept in different diseases, and really astounding transfer across these conditions. And this is the part, a lot of why we're doing the work we're doing right now is we really want to help our learners understand that the basic science mechanisms behind these different conditions has really important implications for patient safety and reducing harm. Because oftentimes, for example, our learners will think, well, yeah, I'm just getting kind of grilled on rounds about the basic science mechanism, but like, what does it matter? They're just trying to see if I know my stuff. It's like, no, actually, it may have an important difference in addition to a good history and physical and looking for the other clinical features and good clinical reasoning, for example. And then the fun really becomes then extending that. So if you think about this now, each of those integrated illness scripts each has additional core concepts that support dyspnea in that. So for example, if he has a PE, she has to also think about the interrelationship of regulation of O2 and CO2. If he has asthma, she has to think about that plus the fact that there's also structure and function of the CNS and PNS related to his bronchoconstriction and how that works. And lastly, if he has pneumonia, she has to think about the concepts of like acute inflammation and even chronic inflammation as it relates to asthma. So it's kind of fun then to take something like flow and then add the other concepts that really do help you in this compare and contrast between these different conditions with respect to their core concept, not just their clinical features and epidemiology and core clinical presentations as well. So we're going to turn you guys back to the last breakout, which is going to be kind of a fun discussion.
Okay, hang in there. We're in the last 25 minutes of the web shop. So this time we'd like you to consider the two prompts that are shown on this slide. And our Aquifer staff is going to go ahead and drop those into the chat window also for you. So this time we'd like you to consider how you might use the integrated illness script pedagogical approach in your classroom or perhaps in your clinical education setting, maybe at the bedside. And how do you think the kind of deeper understanding advocated by the integrated illness script advances safe and effective patient care decisions by learners? And the decisions we ask you to focus on for that prompt are further workup, management, and patient education. And I know some of you are already starting to think about that. So please use your time. You've got 10 minutes. Use the time however you feel is most productive. but we would really love to hear your thinking about these prompts or other things that are really standing out to you now. So we'll see you back in just about 10 minutes. All right, I think we've got everybody. So I invite you now again to just go ahead and unmute and please share with us from your team discussions. So let's start out. Did anybody talk about how you might think about the integrated illness script approach in your classroom or bedside clinical settings? John Zarek, I know your team is thinking about this.
Well, and as I mentioned when we were talking about this, because briefly we're undergoing a curriculum renewal, and we literally just more or less got started in January because of COVID derailed us. So, but we're expected to roll it out for the new class in August, and we have kind of a flow in our mind, a framework where our case-based learning and our end of week integrated exercise and the integrated weeks that are going to be built into the curriculum periodically are all going to be, the foundation are going to be the integrated illness scripts. So, and starting out early on, thinking about being very prescriptive with the students, because we learned today it takes a while for to create one of these, but, just telling the students, in CBL, this is, what's the causal mechanism of cough if you think this patient has asthma. And then with the integrated end of the week, revisiting that with a clinician in the room, hopefully if we can get a clinician in the room, to kind of walk through, an integrated illness script or a pair at the end of the week, just to wrap up what the students have been learning that week. And then with our integrated weeks, we've been thinking about this idea of comparing and contrasting. But having that kind of as our framework or our foundation as we're thinking about this. And as I mentioned in my other group, the breakout room here, if it sounds vague, that's because it is. We're still kind of massaging it in our brains to figure out how it's working. And we thank Kit and Amy for meeting with us on multiple occasions to help us think through this.
Yeah, and John did say they're launching in, I think, less than 3 months. So it better get less vague soon, I think, John. For schools that do problem-based learning or case-based learning, I think this is what students need to be doing, actually. They need to be able to explain everything that's happening with that patient. They surely need to be able to explain all the symptoms, all the clinical findings that they see in that patient. And this gives them a framework by which to organize that. I would also suggest in team-based learning, the integrated illness script and mechanism of disease maps could also be very valuable. I know we didn't talk a lot about the mechanism of disease maps today, but for those of you who do team-based learning, I could easily see students in real time creating a mechanism of disease map and then doing a gallery walk. When it's easier when you're in person, but you can also do it virtually. Do a gallery walk and let students vote on which is the best, or dividing up the different branches of the map. So any other thoughts about classroom activities?
We do the mechanism of disease maps now, and it's in first year, and it really is a great way to integrate both the different disciplines as well as with clinical ways. But I like the structure of these illness scripts and to introduce it really early so that that's the way they put the information into their head to begin with, because I understand, and Leslie probably could tell us that that's the way physicians think in illness scripts. And so if you've got it in there to begin with, that seems to be the most efficient way to learn the material.
Yeah, and I think, Leslie has made this point so many times that, right now we're teaching students all this knowledge, all this foundational science, and then they get into the patient care setting and it's not organized right. Like all that knowledge that we spent all that time teaching and they spent learning, it's just not organized right. And it looks kind of like my basement, which is a black hole. Like for anything that goes down, there's like a black hole. You can't find anything. Like that's how students feel when they get into the clinical setting. And so a big part of the work we're trying to do is to create these frameworks and to organize foundational sciences in a way that students can access and use them when they're with patients.
Well, and Amy, I'll just riff on that quickly because there is so much great basic science being taught by fantastic basic scientists. And I think that's, as my early frustration is it's just gets kind of packaged in a box and set aside and they start all over again. Rather than, I think it's just a matter, I like how you said that, it just, it's just a different framework, same fantastic science, just organized a bit differently.
So let's move on to thinking about how this type of deeper understanding could advance safer and more effective clinical decisions. So if you're thinking about further workup, what additional tests do I need to order? What additional tests do I not need to order? Management, again, pharmacology is my favorite. And patient education. We touched on this a little bit. So how can this help with patient education? Any thoughts about that area? Or at this point, I'll say anything else you talked about in your groups that you'd like to share.
I would like to bring up a good question that Michael had for our group, if you don't mind me bringing that up, Michael.
Not a bit. Go ahead.
I guess one of the barriers to getting student buy-in to this early in medical school, how do we bridge what senior clinicians know students need to be a good clinician versus the incoming medical students who are only focused on board examination and multiple choice questions? And how do we use illness scripts to either do both or to get student buy-in?
So I'm going to start, and if Leslie wants to follow, because I actually had this epiphany just last week. So it's a good thing you didn't ask me 2 weeks ago. I am so personally frustrated that students are so hyper-focused on step one and the shortcut of the board review resources, that they are applying that shortcut to all of our curricula. And now I think what we are seeing nationally, and I don't think it's just the pandemic, I think a lot of us are seeing students who are not so ready to sit for step one. And, even after a study period. And I think the reason that they are not doing well in their dedicated study periods is because they don't have the foundation. They have tried to build their knowledge for practice around shortcut factoids, Anki decks, and they don't have that true conceptual underpinning for their foundation. And so they're struggling. So these resources that are supposed to prepare them to do well on step one, in fact, they're not doing it. And the integrated illness scripts and mechanism of disease maps and the classroom activities that we are building associated with those, I think, do it. I think they will be a nice resource for students and for teachers, but they're going to create that conceptual foundation that students need and must have to do well on step one. Okay, now I'm going to step down from my soapbox.
Well, Amy, I'll just say, as we're closing, I think Mike, it's a great question. And I think that the way as a clinician, what I would really ask the basic scientists to help us as clinicians start to do is, I used to teach an elective, a nighttime elective with Dartmouth medical students, teaching them how to create integrated illness scripts. And I knew this was a challenge. Like, they also really wanted to focus on studying for exams. And so what I did was I asked them to begin to think about where do those questions fit in the context of the illness script. So if they're studying this much more granular information, granted, there might be 2 or 3 big jumps between this granular information and the condition, but I really asked them to sort of use the illness script as sort of like their Google Maps, if you will, in their head. And, you know, right now they just sort of need to figure out where this house is in this bigger map. And I said to them, I think it will help you better understand the information and it will help you retain it. Now, can we prove that? I don't know. But I do think, I agree with Amy. I think in many respects, just having any level of contextual help helps people remember where that information is stored and what they might need it for, you know, because literally the next patient is the next question on the exam, and helping them recognize that component of it, I think, is really important too. But as a clinician, and Mike's a clinician too, we really would love to have the basic scientists help us, help the students make that connection, to help us then take that and then help them apply it to the patients we see. So I think there's a role for us there in literally helping the students make those ties, because frankly, they'll tell you, they just don't have the time. So I think the more we dive into some of these question banks that they're using, or that we're asking them to use with some of these, you know, some of these other tools they're using, the more we integrate those into their use of illness scripts, the better I think they'll remember the information for the real everyday problem of actually passing these exams that are still pretty picky.
I have a quick question. One of the things one of the first figures that you showed was that there's like a 7% difference between, you know, illness scripts and other types of learning. And I'm just wondering, has anybody done studies, or maybe this is new enough they haven't, in which students kind of prepare for step 1 using illness scripts or that type of modality, and then came back to study step 2 clinical knowledge, that maybe they didn't have to study some of these topics as hard or as much because they remembered a lot more?
I mean, I think it's a really great question. You know, we are right now just rolling, you know, this pedagogical approach out. So I think all questions about, you know, are there outcomes that show this, are great questions, and we would invite you, you know, to help us look at those as well. But at the end of the day, what I will say is, we know that better organization of knowledge in a way that it can be applied to a new problem, which, as I said, new, you know, step 1, step 2 questions are new patients, they're new problems. The more we help our learners organize that information and not just have to memorize things that are scattered and then come back again, the better they'll remember. I mean, just basic cognitive neuroscience tells us that. So it really is our belief that this will improve that, but certainly, is that something we can prove yet? No. Is it something that we'd like to collaborate with everybody to help prove? Absolutely.
Can I say something to both Amy and Leslie? I introduced the straight illness scripts 4 years ago in our case-based learning for second years, not your integrated, just the straight.
Mm-hmm.
I had the first class that we did that with come and ask me to please, did I have all the illness scripts put together sort of as an illness chart, because they all used them to study for step 1.
Yeah.
They found that by using them, it framed the question. And the next year, when they got into their clerkship and they were taking their OSCEs that in the 3rd year, their differential diagnoses improved by at least 60%, having had the illness scripts, and they added to them. So again, I didn't do a study to prove this. I just know because I bridge both the clinical years and the preclinical years. And now with this integrated illness scripts, it takes it to the next level. But you got to start right from the beginning.
Yeah, thank you, Tony, for sharing that. That's really encouraging.
And great to hear. That's very heartening. Thank you for sharing.
Yeah. Leslie, you want to go ahead and close us out? If you don't mind committing to some idea that you have, we'd encourage you to put that in chat, but we're gonna go ahead and close out so we almost stay on time.
Great, thank you. And yes, please do. You know, we all know that committing to something, you know, helps us take the next step, but I think for us also helps us better understand really how and where these tools are useful to you and your learners from what you're seeing today as well. So thank you, everybody. We know it's the end of the day, and it's, you know, you put a long day in already, and so we appreciate that you're, you know, choosing to close it out with us today. Our team is putting the asthma worked example in the chat. So you actually have our worked example, which I will tell you also is the demo integrated illness script on our website, if you want to go see it there as well. But we're putting that in the chat for you. Please do take a minute to fill out the survey and let us know, what really met your needs today, what great ideas for you that you have for us, going forward and offering these to others as well. We would love to see all of you at our How to Create a Mechanism of Disease Map web shop that we're doing at the end of June. So we really, really invite you to that, as well as we will continue to put on sort of 201 level web shops in the future for how to continue to advance your skills in creating integrated illness scripts and MOD maps. So any feedback you can provide us today with things that work well or things we could improve will help us make those even better as well. And lastly, we have all kinds of great resources that we put in the chat as well. We have a paper that, as I said, we recently published. It's open access. So you're welcome to share that anywhere that you'd like to with people too. It's also on the references list and also on our resources page on the website is our new white paper, talking a lot about illness scripts and MOD maps as well. So once again, just really, really, really grateful for everybody's time, to our coaches as well for the fantastic job they did. I think really running some great breakout rooms, and hope everybody has a fantastic evening and or rest of your day.
Bye, everyone. Thank you.